Okay, today we're going to talk about thick blood. And a patient told me today he was told in an emergency room that his blood was thick. He had no symptoms except for new onset hypertension. On exam, he had a little bit of facial plethora, and I got blood work on him, and he had a hematocrit, 69.9, and a hemoglobin of 22.2. It's probably the highest I've seen. So how do you approach this? Well, he clearly has an erythrocytosis. And his white count was also 22,000, and he had a platelet count of about 420,000. So how do you approach this thick blood? Besides getting them to hematologist right away, you need to make a diagnosis, okay? And the number one thing you think of here is polycythemia vera. His hemoglobin and hematocrit are very elevated, his white count's elevated. Platelet count's in the normal range, but it's high normal. And with that, you really get a JAK2 mutation panel, which will be ordered. Used to be in the olden days when I was a resident, you had major and minor criteria, and you had an elevated hematocrit greater than, I forget, I think it was 52 in a man, I could be wrong, and 48 in a woman. This is old school. White count that's elevated, and platelet count that's elevated. And then the minor criteria were an elevated leukocyte alkaline phosphatase and increased B12 binding capacity. And I'd have to look up some of the other ones. This is real old school, and it's not used anymore, but you had major and minor criteria. And basically, this is negative, you get an epigen level. So you can divide causes of erythrocytosis into decreased epigen or increased epigen or erythropoietin. Epigen synthetic erythropoietin. Erythropoietin is produced when the body gets hypoxic. So the things that cause that, or anything that causes hypoxia, advanced COPD, any type of interstitial lung disease with hypoxia, obstructive sleep apnea. Often these patients will have higher than expected H&Hs, or obesity, hypoventilation. Okay, the other thing that could do this, erythropoietin is made in the kidneys. So certain renal problems like renal cysts, tumors, they've reported this with renal artery stenosis. Then anything that causes a shunt, which could cause a right to left shunt, or an abnormal hemoglobin with decreased carrying of oxygen. And the other thing are tumors. And there's certain tumors that excrete erythropoietin, hepatoma, hypernephroma. It's been reported with ovarian, with pheochromocytomas, and these unusual tumors, uterine fibromas, and cerebellar hemangioblastomas. And this is kind of medical trivia, hypernephroma, uterine, cerebellar, and these are the causes of this. So the way you approach that is really, ruling out P. vera, and if that's negative, then you can look for other things, especially pulmonary, renal, and tumors. And this patient was not hypoxic. They probably require a CAT scan of the abdomen, but the first thing you do are the JAK2 studies. Okay, this is very concerning. You're going to have to get this H&H down quickly, otherwise this patient could suffer a complication related to hyperviscosity, like a stroke. And I would imagine the hematologist will put him on a drug like Hydrea initially, and if he has P-Vera, and then he'll need phlebotomy and possibly other treatments like interferon. But they need to get the diagnosis. When your blood is thick, you think of P-Vera, and if the studies are that or negative, you get an EPO level. Okay, and if that's elevated, you look at the causes of elevated erythropoietin, and they fall into pulmonary causes most commonly, sometimes renal causes, abnormal hemoglobins, and tumors. And that's a quick talk in thick blood. Thank you.